A very good evening to everyone. Doctors, nurses, business leaders, academics, students, educators, healthcare professionals, coordinators, engineers, scientists, designers, support systems, family, friends, and friends I've not met yet this evening. Welcome to Hacking Rural Medicine. So, I'm Shalene Liu. I'm your host for tonight. I'm a graduate student at MIT and a member of MIT Hacking Medicine, and it gives me great pleasure to tell you that tonight you are part of history twice. This is the nation's first ever Ignite event dedicated to rural medicine. What makes it even more special? You are part of the country's very first rural medicine hackathon. Give yourself a round of applause for being such trailblazers. Woo! So before we start out this evening, I'd just like to take the opportunity to thank our sponsors who have made this weekend possible. Please hold your applause until the very end so that you can give a super duper applause when I'm finished with all the sponsors. So thank you, a very big thank you to Frontier Medicine Better Health Partnership, MIT Hacking Medicine, Blackstone Launchpad at the University of Montana, iVantage, High Stakes Foundation, Elevant, Benefits Health System, Lean Healthcare West, PNW Health Science, Health Technology Services, Mountain Pacific Quality Health. Thank you also to AHEC Montana, HMSS Montana Chapter DMNL, Providence St. Patrick Hospital, Fatmoose Media, Cross TX, Frontier Rural Innovations Network, Staples, Submittable, Blue Sun Photography, Intenio Systems, Bobrow Williams Group, Rural Assistance Center, MCAT, SMART. And let's give them a big thank you for sponsoring Hacking Rural Medicine. So this weekend really wouldn't be possible without the great team that's had their boots on the ground and knee-deep really in making this weekend possible. And I'd love to be able to thank, led by Monica Bourgeot. You'll see her around. You can thank her later. The team includes Harold Shinsato, Paul Galden, Denise Trader, Jeff Mangan, Jen Stevens, Justin John, Ben Power, Tatiana Gubin, Alex Revelos, Molly Binder, Rebecca Morgan, Kate Valerio, Audrey Wooding, Brad Knowlton, and tonight, something very special for you. We're fortunate to have with us Alex Alviar, who will be here right at the side. He will be doing graphic capture for the opening and closing keynote. So at the end of it, we'll have something fun to remember these two speeches by. Thank you also to all you amazing people who have helped out in one way or another. Please give this organizing committee a round of applause. So now I get to introduce the event proper. We're here tonight at Hacking and Ignite Rural Medicine. Show of hands, how many of you here have been to a hackathon before? All right. How many of you here have been to an Ignite event before? This is awesome. You guys are coming here with no preconceptions. It'll be such a great weekend. So this is appropriate. And let me set the frame, and here's what we set out to do. We're here tonight and this weekend to share ideas and to connect with one another. But what we're also going to do is to take this beyond ourselves. We're going to share these ideas and connections, build upon them, and really create awesome solutions to help our rural communities and make impact beyond this weekend. Am I right? Are you with me? And of course, we'll try to have some fun while at it. And I think the organizing team has really got a great weekend set up for you. So, without further ado, and to get ourselves started on this great evening and weekend ahead, I have the pleasure of introducing our first keynote speaker, Dr. Terry Hill. Dr. Terry Hill has more than 28 years of professional experience working with rural healthcare providers and their communities. He is currently Executive Director of Rural Health Innovations and founder and senior advisor to the National Rural Health Resource Center. In the past 5 years, Terry has facilitated 6 national summit meetings on various rural health topics, including health information technology, rural hospitals, quality leadership, performance improvement, and rural health networks. Currently, he serves as part of the adjunct faculty at both University of Minnesota Duluth Medical School and the College of St. Scholastica, where he teaches health policy and performance management, respectively. The long and short of it is that Terry really is a visionary for what rural health can be and has been one of our biggest supporters for this event. We're really lucky to have him kicking off our weekend for us. So without further ado, Dr. Terry Hill, please give it to keynote address.
Thank you very much, and it's really a pleasure to be here. This is a really exciting event. I've got about 15 minutes to kind of lay the groundwork for the American healthcare system, where it is right now, where it's going, and how rural communities can kind of work together to make the future more successful, let's say, than the past has been. Now, the main points here, let me see if I've got them. Okay. Okay. First of all, we have to understand that the U.S. healthcare system is undergoing dramatic change. This is not a mirage. This is not a political story, etc. We are moving very rapidly into an entirely different healthcare system. How do we know that? Partially because we spent a lot of time talking with the Mayo Clinics of the world, the Cleveland Clinics, American Hospital Association, American Medical Association, National Rural Health Association, etc. It's pretty much a consensus that we are moving in this new direction. The new direction is going to be very, very different than the old system. In essence, what we are coming from is a system where we paid for medical procedures and did not pay for wellness, did not pay for prevention, etc. We're going to move into a new system where this is going to happen. It is already happening. The current Secretary of Health and Human Services is projecting that within 3 years, by 2018, 85% of fee-for-service payments will change into this new value-based system. The road ahead for rural health care providers is going to be very challenging. We've always been challenged. We have fewer resources. But we have a lot of things going for us, and I'm very much an optimist about this, both in terms of where the industry is going and also in terms of what rural is going to emerge from in this new system. Our rural healthcare providers and communities can lead the way in system reform, and I'm really pleased to see this hackathon being held here, that we're actually working together as community leaders, as a variety of different healthcare providers to forge a new future. And we're going to have to work together if we're going to create the value that we're going to need and to maximize the health of our communities. I mean, it's truly going to be about keeping people healthy, about providing value, and about finally kind of reconstructing the American health system. Now, this is a quote from Joseph Stalin, and I used it because I have something to say about both of the sides of this quote. One death is a tragedy, he said. 1 million deaths is a statistic. And in essence, millions of people died in Russia under Stalin's regime, and basically because it was a statistic, he was pretty much able to get away with that. The tragedy, basically, I want to talk a bit about is my mother died just a few days ago, and her funeral was this week. And for me, that really was a tragedy. For my entire family, it was a tragedy as well. And during the course of the last dozen years or so, she has gone through the American healthcare system and has seen both the good and the bad. At the end, she was in an assisted living facility and had just an extraordinary team of professionals that worked with her, that loved her, that basically kissed her goodbye as she left. 9 of them actually came up and told her that they loved her and kissed her. This was a rural assisted living facility. This is what we have to offer. It's that personalized care. And my mom couldn't have been taken care of any better anywhere else in the world. She also had a lot of experiences in the bigger hospitals in the Minneapolis area. And there were a lot of medical mistakes made. There was a lot going on. There was a tragedy for our family in general. We've got to take this out of statistics. We've got to put it into your family, my family, etc. If you don't have one of these tragedies in your family, I hope you never have it. But in essence, we all have children. We all have mothers and fathers, etc. So for me, this is very personal. Next. So the million figure. The projection is this is a very conservative figure. Even the American Medical Association would agree with this. Over a million people are hurt or killed every year by medical mistakes. That's the million figure from Stalin's quote. It's from about adverse drug interactions. There's about 1 million of those that take place. Hospital-acquired infections, hundreds and hundreds of thousands of those. Inadequate care coordination. And finally, overtreatment. The overtreatment, by the way, may seem rather benign, but when you really look at what that does, we find that the more treatment, the worse the outcomes. The more money spent, the worse the outcomes. I'll give you an example. Florida, the #1 spender of Medicare dollars. They're spending approximately twice as much per Medicare patient than some of our rural states. So if they're the #1 spender, they are the number 50th in terms of quality. The #2 spending state is number 49 in quality as well. We have a ton of overtreatment, and we're going to have to do something about it. Particularly stuff that is done in excessive medication, excessive procedures, et cetera. Next. So what is this system that is based on volume brought us? It's brought us the highest cost in the world, over double than the next highest country. So for example, we are roughly double what they pay per capita in Canada, in England, in Japan, et cetera. So this is one of the primary reasons. You'd think it would be enough that we have a system that doesn't really provide the care that the American people deserve. But in essence, it's very much about the cost at this particular point. Healthcare will bankrupt this country if we don't do something about it. The cost of chronic illness alone is now well over $1 trillion, and the projection is if we do nothing, that's going to go up to $4 trillion by 1929. Something's got to be done from a cost standpoint. I'll also give you an example. If our wages continue as they are and healthcare inflation continues as they are, in essence, according to the Kaiser Family Foundation, within 20 years, we're going to be paying 51% of our wages for healthcare premiums. So every dollar spent, if the employer's not going to pay it, then we're going to be paying more and more of that as well. Lower quality, we rank 37th in the world in terms of quality. I don't have to go into any greater detail. This is not value. And quality itself, despite the great efforts of the many, many healthcare providers are out there, we simply have a dysfunctional system. Very high chronic illness as well. I have a statistic in terms of we have a crisis just in terms of the mental health of our children. We've had a 3,500% increase, 3,500% increase in the last 20 years in the number of children who are now basically classified as mentally ill under the SSI system. Diabetes is out of control, et cetera. And part of the reason has been we don't pay for chronic illness management. Low access, we've had about 50 million people that have not had insurance. And so this system, it deserves to go away. It is the people that work in it are victims as well. And I can tell you that I give this talk across the country, and I get no pushback from anybody in terms of this. Next. So the old system was based on value, on volume. The new system will be based on value. So let me tell you a little bit about it. The next slide. The new system is really focusing in, and I mean it sincerely, on better health, better care, and lower costs. And it's possible because we know lower costs is possible because even by the American Medical Association's own calculations, we are basically wasting between 1/4 and 1/3 of all health care that's provided. Those are probably pretty conservative numbers. In other words, pure waste. So if we diminish that waste, and there's tons of ways to do it, we're going to be able to lower that cost. The care being 37th in the world is nothing to be proud about. We certainly have room for improvement there. But the big thing is going to be about better health. And that's going to take a community effort. And that's why I hope you're all here at the hackathon, because we can't do it alone. In essence, 40% of the outcomes, health outcomes, has to do with lifestyles and personal choices on the part of people. 30% has to do with genetics. About 15% has to do with other factors that kind of that revolve around the environment and about other things as well. And only about 10% of health outcomes are going to be determined by healthcare providers themselves or by the medical system. Next. So there it is. Quality plus health over cost is what we're going to need in terms of this patient value. And the new type of healthcare organization that is forming across the United States is called an accountable care organizations. We already have over 600 of them, and we believe by the end of this year and the beginning of next, we'll have over 1,000 as well. Now, there's not that many in rural areas, but there's no question about the fact that Medicaid is already moving very rapidly into this area. They're already talking about how much money that they've been saving in Oregon, in Minnesota, in Colorado, as such. And under this accountable care organization, we're going to get paid for the first time to keep people healthy and to manage chronic illness and to basically address some of our higher cost patients. Hospice is going to emerge. I could go on and on, but believe me, that whole value statement is something that Mayo Clinic is using. Again, everybody understands that's where it's going. And in essence, the challenge is going to be how are we as rural communities going to be able to survive in this new environment. Next. So we've got this image up there. We're going to have to go from the current system where we are right now, how we're getting paid, into this new environment, and we've got to be very careful as we go across because we're still partially under the old payment system and we're moving into this new payment system moving forward. Next. So here's the reason for optimism. Here's why rural communities do not have to be victims. We have a whole lot going for us in this value-based system. First of all, the new revenue stream of the future, the new basic value-based systems that are emerging are really built on primary care and primary care providers. Now, we have one primary care provider in this country for every 4 specialists, while Canada has one primary care provider for every specialist, and most of the other countries do as well. We're going to see this shift gradually as we're moving forward. But we have, our healthcare systems in rural areas are built on primary care. We have lower beneficiary costs in rural. We have reimbursement advantages because of critical access, hospitals, et cetera. Rural can change quicker. We're smaller, we're more mobile. It's very, very difficult to change these great big systems. Now, surgery used to be a major revenue center. It is now going to become a major cost center. We don't have a whole lot of problems in that regard in contrast to some of these bigger systems. And rural is more community-based, and that's going to be at the heart of the success formulas. Go ahead. Now, this is the blueprint for value that we've put together. This was done in collaboration with providers across the country, organizations, et cetera. We feel these are the most important pieces that need to be accomplished in rural areas. The top of the list is leadership alignment. And I'm not just talking about medical leaders or hospital leaders. I'm talking about community leaders, leaders of all the other different type of healthcare services, leaders pretty much in all of the rural communities as well. We're going to have to create a vision and strategy that is going to be motivating. And if we can't translate this into how it's going to help our kids and our parents, et cetera, then it's going to be extremely difficult. We've got to build that way to get across the shaky bridge. It's going to be very important to have partnerships, care coordination, and very active community involvement. I don't have time to go into all of those, but it's going to mean actually reaching out to various types of healthcare services you know, mental health, schools, everybody else, they're going to all have to work together here if we really want to make an impact. There will be every motivation, I promise you, on the part of healthcare providers to include these kind of non-traditional healthcare entities. We've got to use data and information to make our decisions. It needs to be evidence-based. We need to have a change-ready and adaptable workforce, working as teams now. Physicians will have a role, but what we're going to be seeing and already seeing across the United States are care coordination teams that are basically working and helping the patient from entry into the system to the time they get into home, and then following up at home as well. We're going to have highly efficient, we're going to have to take the fat out of the system. All the inefficiencies are going to have to go as well. And we think that's going to lead to excellent performance and success in that value-based systems. Rural is going to do it. The big question is, are they going to be willing to work together and do it in time? Next. So my favorite slide of all time, that's how we're going to do it, by working together. To me, that's the perfect thing for the hackathon. We need to spread innovation, and the only way we're going to do that, as I said, is working together. Next. And this is a quote from Will Rogers, even if you're on the right track, you'll get run over if you just sit there. We cannot afford to sit there. Those of you that showed up today are indication that you're willing to come and participate in this very exciting event. So with that, I'm going to thank you very much, and we'll have our next speaker.
Thank you very much, Dr. Terry Hill. Those were great words of optimism to start us off on our weekend on maximizing health by working together and rural communities being able to lead the way. So now we begin our exciting evening diving into the opportunities and challenges of rural medicine. And for those of us who have not been to Ignite event, which admittedly includes me, let me show you what the Ignite format's about. Very quickly, it's simple, it's exhilarating. Each speaker will present their topic in 15 minutes using only, 5 minutes. 5 minutes. 5 minutes. Harold will kill me if I give you 15. Using only 20 slides. So tonight we've got an exciting lineup. 8 awesome speakers this evening, running the gamut in rural medicine, from analytics to drug costs to employee engagement and to community care. If you're interested, the speakers' bios can be found on the website hackingruralmedicine.org. So if you're ready, it gives me great pleasure to introduce our first speaker of the evening, Ken Wall. He is the founder and president of Geodata Services, Inc. And Ken has 26 years of professional experience as a GIS analyst and is an industry leader in GIS and sustainable communities and geodesign. Giving us our first Ignite talk of the evening, titled Web Mapping for Community Health, please welcome Ken Wall.
Maybe exhilarating for you, but kind of nerve-wracking for those of us doing it. I'm a GIS guy, Geographic Information Systems specialist. I've been doing it for 30 years. I'm going to talk about 3 projects tonight here in Montana, all of them health-related. And it relates to the sea change that I've seen in my career with geographic information systems. We're now in the day where we have everybody using smart devices and smartphones, tablets, and we're in a web environment now, and that's where GIS has come. So I get an extra few seconds here. We're a small company, we're a consultant. The 3 projects I'm going to work on or talk about tonight, one is with Department of Health and Human Services, the Montana Health Department in Montana. The second is with United Way, and the third is with a regional consortium up in the Golden Triangle, north central Montana. These kids, this is the REACT group. It's a youth group, youth movement in Montana and around the country. They converged on the Capitol here in Montana last year. We're in our biennial legislative session. And they cornered legislators, their own legislators from each rural community and urban community. And they showed a beta app that we just released 2 days ago with Health and Human Services. It's called the Montana Tobacco Mapper. These kids are fighting corporate tobacco. Corporate tobacco can't advertise on billboards or on television, but they pump $8 billion a year into convenience stores, into liquor stores, and places that you buy tobacco. So these kids are basically, we're working with tablets and their own smart devices, and they were talking to their individual legislatures, and we really need that kind of education with the Montana legislature and with a lot of rural legislatures to basically bring them up to speed on health issues and on issues that affect youth. This is much longer than a 5-second slide. This is the app that we're using. It's the first application, web-based app that Department of Health and Human Services has put out. The sea change that I've seen with GIS is it's moved from the back office to the front office. It's moved onto our devices, onto our mobile devices. This application was featured this week when we first released it by Esri. Esri is our partner, largest GIS company in the world. They're developing the technology, the web maps, and the applications that make this happen. This is going to be on a featured app April 6th for Public Health Week, National Public Health Week. So it's a real coup for Department of Health and Human Services and for our small company. This is what the app looks like. It opens up with this branding that occurs in convenience stores. It's an interactive website. It's all built, a little bit of customization, but mostly with off-the-shelf tools that I've been working with schools in Montana. 7th graders can build these tools. Here we're looking at the retailers in Montana that in proximity to schools and how close they are. They're color-coded by how close they are to schools. This is Billings, Montana. This is modeled throughout Montana. This is one of the apps they were showing the legislators. We have it pre-generated reports, so on their tablet or their phone, they can click on the House district or the Senate district of their legislator, show them the density of retail outlets, show them the proximity to schools, pull up the graphs for their small, rural, local area. The data exists from demographics, from the census, from Dun & Bradstreet businesses. Tremendous amount of information, and the power of that to educate legislators and their parents and the public is really critical, and their peers. And it's important to present it on a device that they relate to, tablets, smartphones, et cetera. So these are some of the other tabs. This is built using story map technology. Esri, the company that built this, hired Alan Carroll from National Geographic to build this technology. We've been telling stories for millennia. We've been telling for many, many years as humans, and this is a very effective way. It's much more effective than the way we've done this in the past, which is a bunch of geeks building maps for other geeks. This is for everyday people who can understand how to use these tools. And so part of this is the images that they show, and part of it is the ability to explain this with quantitative data. Second project is United Way in Billings, Montana. We're working with Riverstone Health, Billings Clinic, St. Vincent's there. They're a very collaborative group. Unlike a lot of Montana towns, they have torn down their silos and worked together well. Their program is United Way Maps and Stats. They're using this technology to build the United Way annual plan to connect their partners. They have about 70 NGO, non-governmental organization partners that they're working with. Started with third grade reading proficiency, which is the critical point for kids to be able to read. You'll see these yellow little red circles on several of these slides indicating an area just south of downtown in Billings. And it's the area where the pockets of poverty are. It's where the population in need are in Billings. And a lot of rural communities, that happens in the urban areas. This is a statistical analysis we did, grouping analysis. Same thing, we combined healthy food access, graduates, people that graduated from school. This is 5 years of crime data we looked at. All of these start to target this same pattern in South Billings of population in need. It's where the bulk of the needs are there. In 1966, the United States released the Folsom Report almost 50 years ago, talked about community as an important part of health. It's the community affair. It's the seventh vital sign. They identified that 50 years ago. We're now just starting to begin to realize the importance of community and place as a part of this process. The last thing I'm going to talk about is North Central Montana. This was Vibrant Futures. This was a HUD sustainability project we worked on for a couple of years. This is a very rural area. They bought a couple of Missoula buses to basically handle some of the transport issues of getting people from the rural parts of Montana. You can see, maybe barely see the pattern there of where the acute care for emergency versus the difference for specialized medicine is required. So we've got a tremendous issue in this kind of a region where we cover, four eastern states in one large rural area, Montana. The web maps we work with, it's very exciting for me as a company, working with the kind of technology that we can build these apps without extensive costs. The return on investment is there for communities and for doctors and for hospitals. And I look forward to this weekend and the hackathon to try to see how we can make this work.
Thank you so much, Ken. Our second speaker for the evening is John Legalis, who is the CTO at iVantage Health Analytics. His focus is on creating novel analytic platforms and techniques to enable the success of risk-bearing provider organizations. Prior to joining iVantage, John spent 5 years consulting with venture-backed companies and investors, most recently with 2 healthcare startups focused on bundled payment solutions. So tonight, he'll be giving us a talk on prescriptive analytics, reducing the total cost of care in rural Montana. Please welcome John to the stage.
Wait. I gotta talk here, right? How's that? I'll speak out from behind the lectern. Hi, all. Great to be here in Montana, in sunny Montana, out from Boston. It's nice to be able to see the grass. I'm John Legalis. I'm the CTO of iVantage Health Analytics. We're the data partner for the Frontier Medicine Better Health Partnership, and we've been privileged to work with the organization for about 3 years now. And we've been doing all the outsourcing for the data analytics. So as Terry said, the healthcare industry is shifting from volume to value. It's really important as you're a rural hospital, the pressures that are really starting to bear on that. You need to be able to demonstrate quality and all the aspects of population health that Terry had mentioned, better health, better care, and lower cost. The Montana medical spend, Medicare spend, was about $1.6 billion in 2014, or about $8,000 for beneficiary. That's actually low compared to a lot of places. And the partnership itself has actually done a really nice job so far. There's a lot more work to do, but they've been able to make about a 2% impact over their non-partnership rural peers. So that's a nice success there, and the trends seem to be going in the right direction. So again, better health, better care, lower cost is kind of that 360-degree view of the patient and the way that we impact not only the experience, but the outcomes. And through that, we're able to really look at not only just who's showing up in the hospital, but all the external drivers of disease. So your community, your culture, your economics, your education. We have to look at all of those things and no longer just treating who's showing up in the hospital. Here's, for an example, here's smokers in Montana, and we look for these clusters and use the data to help us guide what specific types of interventions might be helpful in certain communities. And so rather than kind of spreading healthcare around, we use our data to be actionable and to manage and to use data to manage what we can measure and vice versa, basically. We like to look at where we should go as well as measure the effects of our outcomes. So we've got lots of information, great time to be in technology. We've got the cloud for compute. We've got tons of longitudinal data from Medicare, Medicaid. We've got claims data, utilization data. The trick is, where do you focus? How do you put it all together into something that's going to be prescriptive so that you can say these are the people that need to do it? So we do something called prescriptive analytics, which is looking forward. We do cohort analysis to identify those chunks of the population that could best benefit from an intervention. And then we do this thing called pre-post analysis, which is a statistical technique, and we compare basically the before and after and add a dollar value so that we can basically say to the hospital, this is where you need to be focusing a specific intervention. And then we can actually measure the outcome of that, not only in dollars, but in other ways. So we've got better focus, better intervention through prescriptive things. So we're not looking in the rearview mirror, but we're looking long way down the highway about where we should be going. So we've done this for smoking cessation, diabetes, readmissions, some of these potentially preventable stays, things that you shouldn't be in the hospital for if you were well managed. And so we're deploying a number of I guess, laser-like interventions, basically. So why does this matter? Why does this matter to rural? You know, rurals have a real big advantage here because you can make the leap to value very quickly because you're smaller and you're more agile than your urban counterparts. And that's a really big advantage. I like to use the sports car analogy. You guys are closer to your communities. You know your communities. Oftentimes, you're the biggest employer in the place. You've got firefighters, you've got protective services working. You are in a unique position to embrace that care coordination. Because you know your communities, you can gauge the impact of your interventions, more directly and more personally. It's a very kind of hands-on, almost old-school medicine approach, rather than that kind of big system, one-size-fits-all mentality. And because you're smaller, you're flexible, you can pivot. We like to use the word pivot in startup land. You can pivot if something's not working. You don't have all that super tanker inertia behind you that kind of keeps you going in one direction, whether it's working or not. So, the call to action here is perform those targeted interventions, measure those results, trumpet your success, and really importantly, tell these big urban hospitals what you're doing, because quite frankly, you're the incubator for these care innovations that some of these urban hospitals really have a tough time doing. So matter what matters to you. Measure what matters to you.
Thank you so much, John. Now, our third Ignite talk this evening will be presented to us by a pair of gentlemen. Eric Fulton is the co-founder and CEO of Treasure State Internet. And prior to starting TSI, Eric performed information security assessments for Subsector Solutions Corporation, consulted for KPMG, and performed systems administration for Occidental Petroleum. Very relevantly for this weekend, he also teaches ethical hacking at Montana State University. The other half to this duo is Matt Gorecki. Matt has over 20 years' experience in develop and maintain IT systems necessary for an internet service provider. He helped found Montana's first co-working space, The Shop, and volunteers for Code Montana in his free time. So, speaking tonight on how bandwidth changes medicine, please welcome Eric and Matt.
Howdy, everybody. I hope you're all doing well. We're going to speak fairly fast. We don't have slides, so I want you to focus on us and what we're about to say, because it's going to hopefully change medicine, at least I like to believe. So, a little bit about us. I started off as a hacker and actually breaking things, but I want to fix things and make it better. Matt here has been making and building things his whole life. And what we're doing now is we're building bandwidth. And that's what this talk is about, how bandwidth actually changes medicine. Now, we know how it changes our personal lives. All of us like watching Netflix. At least I do. But how does it change the future? How does it change what we do? Now, we've identified a massive problem in bandwidth as it stands, a massive problem that hospitals face, that we face every day. We have an idea of why it's caused, and we have a solution. Best of all, we have a solution. So I'm going to let Matt talk about the problem.
So as Treasure State Internet, we're a brand new internet provider, about a year old, and we were approached by Townsend Hospital, Townsend, Montana. Small town. They had just been through a whole bunch of things, and they decided to upgrade imaging. They got a brand new CT scanner. And it's kind of tough to get bandwidth out in Townsend. So they're paying a couple grand a month for 20 megs a month, or 20 megs up and down. And what they're finding is when somebody comes in and they need a CT image, they're not going to be treated there, first of all. They're going to be sent somewhere else. The internet is so slow that that image makes it there after the ambulance actually gets there to the receiving hospital, who takes their own images in the meantime. And in the meantime, Townsend doesn't get paid for anything that they've done. So what's the solution here?
Well, and even before we get the solution, why is this our current state of medicine? Why is our current state of medicine mediocre, where the ambulance is faster than the data? That is embarrassing. Honestly, I'm going to call out all the other providers, but that is straight embarrassing. It's caused because they don't care, because they're making money, and they don't need to try and look to the future. However, that's what we're trying to do. And that's what we want all of you to do with this hackathon, is we want to look beyond where we stand currently, look towards a solution, because there's something better out there. We want you to develop not for 20 megabits, not for where the actual physical ambulance is faster than the bits and bytes that we send over a pipe. We want you to look at what can happen if speed and distance and time and place were not a factor of medicine. And that's where the solution comes.
So we're talking about, internet service right now is in the tens of megabits, maybe 100 megabits if you're in a larger community. But we can do gigabit speed. We can do 10 gigabit speed fairly cheaply. And so what what kind of things are possible when you have more bandwidth than you know what to do with? I mean, you're talking about, there's tens, there's more than tens, there's hundreds of different things that could change. Has anyone here heard of Da Vinci? Right? The robotic surgeon that right now surgeons operate over the web. You can't do that in towns because it's not fast enough. What we need to think about is not for 20 megabits where the ambulance is faster than the internet. We need to think where a surgeon from Japan can perform a surgery in Townsend, Montana. Right? We need a plan to where you can put on a virtual reality headset and be across the world and change medicine. I don't want people designing for medicine now. For this entire hackathon, if you guys are developing apps, if you are developing anything, don't develop where you can put the data on a USB and drive it somewhere faster. Because that is yesterday. I want all of you to design to where if you could have real-time persistence anywhere in the world, what would you do? Would you create an app that could record a surgeon's movements in a person and could be replayed so that same surgery from a world-class surgeon could be performed millions of times? Because we've seen right now with current existing technology, you can take something and replicate it 100 times. That's the power of technology, the power of computers. And if you could apply that towards medicine, those same powers could change the world. And that's what we want to do. Totally caught off guard there. Yeah, basically not what is current, what can be, right? You know, it's definitely a chicken and egg kind of thing. Everybody's waiting for bandwidth to catch up to it. We're building that right now, even in rural Montana. So let's take advantage of it. Let's think about that this weekend, and what could we do if those things were available to us?
So our call to action to you. I know we all accept 30 megabits per second as now. We accept buffering in YouTube as now. But you can't have buffering during surgery. Because that is when lives matter. And so we're building a network in Montana, in rural parts of the United States, that can mean that real time, someone from across the world can perform a surgery here, change lives, and save lives. And that's what we want to do.
Thank you so much, Eric and Matt, for challenging us to design medicine for tomorrow's internet. All right, so our next talk for the evening, and the last one for this half of the evening is Gary Woodson, who is the pharmacist coordinator with Frontier Medicine Better Health Partnership, where he leads a project focused on implementing an evidence-based cost containment therapeutic interchange program with 25 critical access hospitals in Montana. So without further ado, he's going to speak to us about saving drug costs $1 at a time. Gary Woodson.
We were looking at a project that might be able to give us some immediate savings and then has some sustainable savings, and also be able to incorporate it in a busy rural hospital. And so we began to think about thinking small but saving big, and looking at drugs that are highly used like cardiovascular drugs, and being able to standardize them and also to make them scalable so they could be used in many other facilities, either Montana or throughout the nation. So we decided to use the Therapeutic Interchange Project, which is an auto substitution project where less expensive drugs are dispensed in place of more expensive brand name drugs when appropriate. In this table, it rates costs of drugs from a $1 sign on the left-hand side to a $5 sign on the right-hand side, and the vertical part there is the preferred agents that we recommend in those 4 therapeutic categories. The doses are also outlined there based upon clinical practice guidelines throughout the United States, and also time-tested, evidence-based drugs are being used. We use over $300 billion worth of drugs per year in the United States, and we fill about 4 billion prescriptions. The alarming part of that is that there's more dollars wasted in drugs than there is the cost of the drugs themselves, either for poor drug choices or for non-adherence. And it gets us into admits in the hospital, ER issues, adverse drug events. The cost of not using drugs, about 1/3 of all prescriptions that are written are not even filled, and there's about a 50% non-adherence to the ones that are. Not to leave it on the table, drug savings frees up health resources. In Medicare alone, there's a high spend there over. Also, in the area of Medicaid in Montana, we spend over $75 million there. And then also in the Part D Medicare spend in Montana, 2 of the drugs that are on our table, brand drugs, there's actually $10 million spent in those 2 drugs alone. There's an issue of implementing change of a therapeutic program, and so there's a concept of educating and creating incentive, particularly in the prescribing patterns, and getting busy people within the hospital to go along with it. And there's a tremendous tide of TV advertisements, like $1 million a minute on TV, massive sample programs, and paid speakers that you're working against. You know, how free is free? So if you provided a brand name, a free 1 month supply, and then the copay results in $45 a month after that, how free is that? And then some of the drugs that are on the table are like $1 a piece, some of them are $5 a piece, where most of the preferred agents that we have are 25 cents or less, the same quality. For every $10 increase in cost, there's a 3 to 5% decrease in adherence. So cost is greatly associated with compliance with the medications. We created a reminder sticker because in the hospital we want continuance of the medications that are ordered in the outpatient setting where the greater spend is. So these are crack and peel stickers that can be put at the point of prescribing. You can lead a horse to water, but you can't make him drink, but you can salt the oats. So we're trying to create a incentive, time savings, lower cost, evidence-based, better care. And this becoming more cost conscious by expanding it to other sites, expanding it to other drugs, other drug categories, making it scalable to other systems in rural communities. So we have a tsunami coming of specialty medications that are very high cost, and so we have to keep one of the lines that I like. One of my favorite nurses, Faith Jones, is we need to keep on digging.
Thank you so much, Gary. So now we get a short 10-minute break, and if Harold is okay with it, maybe 8:05, 8:10? All right. So we got a short 10-minute break until, please return at 8:10. Go out for a stretch. There was some water outside the lecture hall. And we have 4 more awesome speeches waiting for you, as well as a great final keynote that you don't want to miss. And welcome back, everyone. Thank you so much for returning so punctually. We have the last 4 Ignite Rural Medicine talks for this evening. And to start us off for the second half, we have Terry Short. She is the account leader and regional director for the Suda Group. She coaches hospital leaders and physicians throughout the Western states and was previously the director of service excellence at CMC. Her talk tonight is titled Stage 1, Engaged Employees. Our first speaker after the break, please welcome Terry Short.
Should have maybe been stage 1, engaged people, because this is fabulous. So thrilled to be here. I get to live in Missoula, Montana, and travel to do the fabulous work I do. Honored, actually, to be able to coach employees and hospital leaders and physicians, quite a bit of physician work. And I do that every day because I'm really passionate about making healthcare better place to work, better place to provide care, and a better place to receive care in that order. So that's what my talk's about. To do that, we need to change the order in which we communicate. So much in healthcare and in business in general, we communicate what and how, and we don't emphasize the why. So let me start here. Who in the room knows what HCAP stands for? Raise your hands. All right, can you tell me? Oh, we don't have time for that. Anyway, so it's like hospital, consumer, blah, 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 blah. But it should stand for this. It should stand for how caregivers always heal patients successfully, because that's why we're in it. That's why people get involved in healthcare. And that would make a ton more sense to the people who are actually delivering the care. Because what we do is we communicate on a different level and we say, here's what you need to do and here's how you have to do it, and we don't connect to the real purpose and the real why. Whereas if we were concerned about how caregivers always heal patients successfully, then we would know that nurse communication, doctor communication, pain management, all those things that make up HCAPs truly are important. And we'd relate it to a story. Every patient has a story, every employee has a story, every family member has a story. And until we harvest those stories and really help people connect to why they do what they do, little makes sense, because we're really concerned more about CMS and stuff and rules and regulations. But when we connect to the stories, it all makes sense. So when we think about the CNA that meets the 5-year-old one day and kneels at his bedside because he's in for his third treatment, his third round of cancer treatment, and she asks him, what is most important to you? And he says, to get to Disneyland at the end of my treatment. And then she goes home and she opens her closet and finds Mickey ears and all the stuffed animals from when her kids went 10 years ago. And she brings those things back and fills his room and helps his experience be different than it might have been. Because she's communicating on a different level and she's connecting back to what it is she does and why she does it. So those stories have to be harvested, but they're not just the patient stories, they're the employee stories too. So I want to tell you about some employees that have had an effect on my life because they've connected to their why. And I'm going to start with Sid, who's coming up next. Sid is a cardiac cath tech in Southern California in a very busy hospital that has a hospital blink of an eye to the right, blink of an eye to the left. And he was really stuck. He was what I would call clinically very competent, and actually, when it's a female, I say nasty nurse Nancy. And I'm referring to that person that actually clinically is very competent, but horrible around their peers, horrible around the physicians they work with and their patients. That was Sid. I had the pleasure of coaching Sid and helping him develop a different way to communicate. But before I could do that, I got to talk to him about his own story, and I found that he did what he did because he watched his best friend die when he was playing football senior year in high school, and of a cardiac arrest, and he determined that he would commit to providing care on some level. So it's people like Sid that you got to connect back to why they do what they do. And so when he turned himself around, his cardiologist said, I'm going to bring more patients here now. Volumes were up in his hospital solely because Sid turned himself around, because somebody cared and helped connect him back to his purpose. But that doesn't happen easily. The very busy leaders and the very busy staff members can blindly go past each other on a daily basis. And until we stop and we say, what does right look like? What are we doing well? And how do we show that appreciation to each other? I'm a huge believer of thank you notes. And I mean handwritten to your home thank you note. I mean your family sees it, you stick it on the refrigerator, it sits on the mantle of the fireplace, because that's what reward and recognition needs to be. That's when we really start making a difference, and that's when people find themselves connected back to why they were called to healthcare in the first place. It's got to start there, and I'm glad that everybody's here to figure out ways and different avenues into a better world of healthcare, but truly rewarding and recognizing wildly and widely is the place to start, because you can figure out all sorts of kinds of things, but if you're not dealing with the passion that needs to be ignited within the individuals that provide the care, then we're never going to get there. So it needs to be in order of why, what, and how. Thank you.
Thank you so much, Terry. So if you take back anything today, you take back HCAPS means how caregivers always heal patients successfully. All right. So it gives me great pleasure to introduce our next speaker, Tawny Sabin, who is the Director of Lean and Community Coordination at the Frontier Medicine Better Health Partnership. Tawny's career began in Intel Corporation. She then attended law school while interning at British Telecom and participating in the Technology Entrepreneurial Program in partnership with Pacific Northwest Laboratories. She's going to share with us tonight how she's used her broad toolset to improve rural healthcare for Montanans, with her talk on Community Care Coordination, Unleashing Your 12th Man. Tawny Sabin, please.
Hi, and thank you so much for having me here, and I've really enjoyed working with those of you that I've worked with over the last year. Just a quick disclaimer, as an attorney, I am by no means a football guru or expert. However, I will cheer on the Cats every day, win or lose, so woo, go Cats! All right. So traditional healthcare is much like a powerhouse and football team from our childhood memories. You know that team that you sat on the couch with your dad and your grandfather and cheered on? But to truly deliver to our fans and our patients, change is needed, as you can tell to readers, and it's needed now. We're in a new playing field. Rural healthcare already has a shortage of healthcare resources, and as you can see here, 57% of the workforce is 42 years or older and ready to retire. Now, by retiring, what that workforce is decreasing, they're going to start utilizing it more, as well as the payments are going to go down as they go on to Medicare. So the question is, how can we do more with less? So to address that, there's been a change in focus, as many of you I'm sure are aware, patient-centered care, population health. So now more than ever, it's time to bring on that 12th man. Especially with those that are retiring at 65, they're still pretty active. Let's get them involved. So what is the 12th man? Think Seahawks, Texas A&M. Win or lose, they are a community of fans with common goals. With their support, their team can do more with less. So who are your 12th man or woman in your community? Just think about, who do you sit by at the potlucks? Who do you hang out with at the fairs and the rodeos? Who do you support in your community when you go to the high school sporting events? These are your 12th men, and you are one of theirs too. So the clinical healthcare team, those are the first 11. They're the experts. They're your home health, your specialists, your primary care, social workers, mental health, pharmacists, maybe you have homeopathic. Who's your 12th man? That's that informal community network. Think about poker night, that 6 a.m. coffee group, the neighbor that plows your driveway, which is really important in rural America, the casserole queens, the ones who deliver nourishment and hugs, whether there's a birth, death, or surgery. The people, the caretakers, whether it's your plants if you're out of town, your pets, your house cleaning, maybe they watch your child when they get off the bus. And then there's the traditional volunteers, the Meals on Wheels, the person that maybe provides transportation, or maybe someone who just helps someone with errands when they need it. So we probably, many of us have heard this example, but the person at church who knows every single person that's sick in the community and asks for that blessing? Well, they know who's going to be in your emergency room before the emergency room does. So why not tap into these resources that you and your family and your patients have already tapped into and share this information and connect the clinical team? This network is flexible, it's interactive. At times, you may be the caretaker, and sometimes you may be the care receiver, just depending about where you are and what your situation is. So think about a parent, a grandparent, that special neighbor that, at some time maybe they were healthy, maybe they were walking dogs, and then they needed additional help. So how do you help? Think of different ways that you provide in this community of networks. Whether it's just simply gardening, driving, there's just so many ways to connect. All right. So how do we maximize this? One, we need to acknowledge and formalize these existing community networks. We need to de-silo healthcare from the community. The patients in the middle still negotiating with both, working, trying to get all the information between. So we really need to integrate and connect the two to really facilitate this for the betterment of the patients and our community members. Also, we can invest in tools and processes to maximize these benefits. For example, CrossTX is just a pilot that's one of my near and dear to my heart. They've created a communication tool that connects the community to the clinical team via one point of contact, the care coordinator, and this maximizes the valuable, relevant data that comes in, as well as all the different resources available, traditional and non-traditional, so that they can better provide care for these patients. I also challenge you to really ask yourself, have you maximized the talent in your community? Really reevaluate your current processes. I know with EHRs, you can't just put a new tool in and expect it to work with if you have a bad process. Bad in, bad out. So evaluate what you have. Are you using it to its best? Are you connecting the info and the connections? And truly, are you engaging your community and using them? They're out there already networking. So. Thank you.
Thank you, Tawny, for sharing with us how to integrate healthcare and community. Our next speaker this evening is Cindy Jimerson. She is the founder of Lean Healthcare West and a pioneer of Lean for Healthcare, having initiated her Lean work with a grant from the NSF from 2001 to 2004. So based on her 30 years as a trauma system developer and emergency health care provider, she's going to give us an insight of how we can get from waste to opportunity. Please welcome Cindy Jimerson.
Thanks so much, and before we start, I have to explain that this is the first time I've ever worn my Red Ants pants to town, but I wore them for you, Sarah. So I'm very happy to be here tonight because in my 44-year career in healthcare has been spent almost exclusively in rural communities, and this is where I live and love. Right now, it's no surprise to anybody, we're embroiled in healthcare reform, and I think one thing that we've learned is that a piece of legislation is not likely going to save our bacon. If you consider the 9 lovable presidents who've worked with that effort in trying to fix healthcare with legislation, I think that we have to come to the conclusion that we have to do something else. That's probably not just all we can do. That realization led me several years ago to consider improving healthcare by fixing some of the broken processes that don't support us in doing our good work. Interesting concept, right? Which led me to the Toyota production system, not a very likely match for healthcare, except that they believe that the people who do the work and their whole philosophy and their success is based on mining the good ideas from the people who do the work. And I think that we have some real advantages here. Now, before we get on to talking about what some of those approaches can be and what the fixes are, consider the demographics. It's my generation that's really going to mess us up here. There are 77 million baby boomers who started retiring a bit ago, and we have increased the demand on health care. Also, we are retiring out of the workforce, and there aren't enough millennials and digital natives and whatever else to replace us in the workplace. And what that means on a practical level is if I can't hike in the Bitterroots anymore without pain in my hip and my doc tells me I need a hip replacement, I'm going to have to wait, maybe for years. And what happens to old people who don't move around? They don't do well. And their increasing disability is going to add even more burden to a system that's already taxed. So we really have to look at what the baby boomers are doing to us here. There's one other consideration of that three-legged stool of baby boomer retirement, and that is we're going to stop paying big taxes. We're going to stop living with our employer-supported health plans and start relying on Medicare to pay our bills. So the picture is the demand is going to go up, there are going to be more people to care for, fewer people to do it, and less money to do it with. That is an insanely dismal picture unless you consider the next experience. In 1999, Dr. John Carnegie and I observed on a busy med-surg unit in a really big hospital in the East, and this is what we saw people doing. 64% of their time was spent looking for things they couldn't find, clarifying things that were unclear, and doing redundant paperwork. And if you apply that 64% to what our predicted cost of health care is for this year, that means we'll spend $2 trillion looking for things we can't find, doing redundant paperwork, and clarifying things that are unclear. But imagine if we could cut that in half. We'd have enough money to take care of every citizen in the United States and reduce the frustration in health care. So I said that rural people have an advantage over city folks, and I think that John already touched on that. We have smaller and less complicated systems, and we have really good access to our leadership, and they're more involved in problem solving than you could ever get in a large community. So it is only through mining the good ideas of the people who do the work that the complexity and frustration in our systems can be reduced. Our goal then is to try to recognize, is to go out and recognize those obstacles that we have to work around in our daily work and try to work with more continuous flow. It feels better, it looks better, it costs less. But it doesn't happen overnight, and it's not automatic. We have to think differently. There's no way that we can fix tomorrow's problems with old school thinking. So this weekend, I challenge you to get out there and think about your daily work and come up with some solutions, like the smart Japanese farmer who put little cardboard forms around his baby watermelons and created a fruit that's easier to stack and easier to transport and easier to display in their stores. I really, really believe we have enough money in our system to take care of everybody, but we've got to get rid of those roadblocks that consume our talent, our compassion, and our joy of work. Thank you very much.
Thank you, Cindy. Thank you for that great exhortation to think differently. So now we're at the final talk for tonight's Ignite Rural Medicine. It gives me great pleasure to introduce Dr. Mark Lindsay, who's an assistant professor of medicine at the Mayo Clinic College of Medicine and medical director for Elevant. He has practiced at Mayo Clinic Health System Eau Claire since 1997, where served in various leadership positions, including most recently as the medical director of ventilator program in Chippewa Falls, Wisconsin from 1997 to 2012. So rounding us off this evening with his talk on post-acute transitional care, understanding the quality and financial impact of critical access hospitals, Dr. Mark Lindsay, please.
So, I'm fired up to be here, and Cindy, I absolutely love your book on A3 problem solving. Absolutely fantastic. We're going to talk about post-acute care and really a nice opportunity for critical access hospitals to grow their post-acute care. We're going to talk a little bit about that. I've had the opportunity 3 decades working in a bunch of different kinds of healthcare settings, academic, large county hospital in Los Angeles, a transplant program in Los Angeles, and an integrated healthcare system in Northern California. And critical access hospitals were one of the highest forming teams that I've been able to experience. Big fan of Pete Carroll, Seahawks, USC, loved surfing. That's my son Matt when he was a little kid. But, and I really believe that do it better than anyone else has ever done it before. That could be a good motto for how we can do it for rural hospitals. I'm going to talk a little bit about the most vulnerable patient population, highest risk of morbidity, mortality, and readmissions, ventilator patients. We're going to talk about COG closures. Maybe this is an opportunity to prevent some of those. And ventilator patients have the highest risk of morbidity, mortality, and readmission, costing the billions of dollars. We implemented a program in Wisconsin. We had a dramatic increase in the growth of the program, team-based processes, respiratory therapy, nurse-directed protocols, getting patients out of the room, de-emphasizing technology. When I was at Kaiser in Northern California, we used non-invasive ventilation to help prevent patients from going on a ventilator. We now use it to help liberate a patient. We're able to have better outcomes at lower cost than any published report in the literature. Transitional care and post-acute care is about passing the mom and Matt test. My mom is awesome. She's 87. She's a school teacher and a mother of 6 kids. Last 3 are physicians. And Matt wants to go into healthcare. I want him to be a part of a vibrant healthcare team. So when I think about providers, teams in transitional care can leverage provider shortages, chronic disease, addressing how we work together to address that, the job losses as well. Post-acute care, tremendous opportunity as a growing Medicare population, and we are seeing more opportunities in transitional care can focus in on that and help the revenues and prevent closures. So when we look at transitional care, it's a partnership of critical access hospitals partnering with acute care hospitals and creating a collaboration where it's a win for the patient, it's a win for the acute care hospital, but most importantly, it's a win for the patient. I took Dr. Wickman, our heart surgeon, to Osseo. It was a community of 1,000, 2 patients the day we were there. We implemented a program, team-based, patient-centered. We dramatically increased the bed days. that place is completely revitalized and has a strong revenue stream. We replicated that in another hospital in Wisconsin, in 11 critical access hospitals, Minnesota, Wisconsin, and Iowa. Dramatic impact on the overall financial status. In addition, we had a 500% increase in the referrals from Mayo Clinic. It became a destination post-acute care site. We had a big increase, 20-to-1 return on investment, and most of these patients went home. And transitional care units in critical access hospitals can be highly functioning. And it's moving these patients that typically are sleep deprived, impaired cognition, inactivity, stressed, fearful, and taking a coordinated care team, empowered care team, optimal sleep hygiene, stress reduction, all of those things. To me, transitional care is a lot like surfing. It's not just about catching the wave, though. This is a whale in Nunca Island up in Canada. It is about really experiencing it, and I think transitional care teams really can do that, do the right thing for the patient. It's not just about doing this in Mayo. This is an independent critical access hospital in Minnesota, not part of a system. We saw a 300% increase in the swing bed days with implementation of the program. They now have a long-term viability. It's a growing population, and they can address that. Respiratory therapy is a vital piece. When these patients get sick, respiratory therapy oftentimes is needed, whether it's congestive heart failure, COPD, or an exacerbation of a chronic disease. Nursing is also important. So we need to learn from our mistakes, and I can tell you that I was more scared than the weasel that took on the woodpecker and didn't make it. I'm never going to jump out of a plane ever again. But I think it is important to learn from our mistakes. Cindy, this is work from John Carnegie, but we basically did frontline problem solving in project in Minnesota, dramatically improved the impact using A3 problem solving. That site participated in an enterprise Mayo project. They had the highest baseline, highest improvement. So I would ask you to find your passion inside healthcare, also outside of healthcare. I'm reading a great book right now by Jan Hills, and it's about you've got to take care of yourself. You guys need exercise. You guys need good nutrition, all those good things. But anyway, take care.
Thank you so much, Mark. Well, I don't know about you, but I thought those were really an amazing, inspiring set of 8 talks. Let's give all our speakers a big round of applause. So finally, to end off this fantastic evening, it is my pleasure to be able to introduce our final keynote speaker. Sarah Calhoun is a community leader, entrepreneur, and founder and CEO of Red Ants Pants. And you've seen some of that good product already this evening. She grew up on a farm in Connecticut and received her degree in environmental studies from Gettysburg College. I'm not going to steal her thunder. She's going to tell you her own story. But suffice to say, she moved to White Sulphur Springs in 2005, and in October 2006, she opened the doors to the first ever company dedicated to making work pants for women. We're fortunate to have Sarah here to share her expertise in rural innovation, the power of rural communities, and how those concepts can apply to healthcare in Montana. Please join me in welcoming Sarah Calhoun.
Well, thank you all so much for having me, and Cindy, that's awesome you're wearing Red Ants pants tonight, much appreciated. So I'm just going to share with you my story in a very rural town in Montana, White Sulphur Springs. This I initially wrote for a TED Talk up in Whitefish last year, and it's called Present Day Pioneering, How We Can Do Big Things in Small Towns. Ivan Doig, one of the best writers of the American West, wrote this of his hometown, White Sulphur Springs, Montana, from his memoir, This House of Sky. It is not known just when in the 1860s the first white pioneers trickled into our area of south central Montana, into what would come to be called the Smith River Valley. But if the earliest of them wagoned in on a day when the warm sage smell met the nose and the clear air lensed close the details of peaks 2 days' ride from there, what a glimpse into glory it must have seemed. A glimpse into glory indeed. Doig's description grabbed me. I first read these words working from my bedroom office in Bozeman, 2005. I was 26 years old and trying to get my workwear for women business off the ground. I had moved to Montana a few months prior, never having visited the state. And as much as I enjoyed Bozeman, I hadn't found my place yet. This continued from Doig. Whatever the prospects might seem, in a dreamy look around, the settlers were trying a slab of lofty country, which would often be too cold and dry for their crops, too open to a killing winter for their cattle and sheep. It might take a bad winter or a late and rainless spring to bring out this fact, and the valley people did their best to live with calamity whenever it descended. But over time, the altitude, the valley floor sits over a mile high, and the climate added up pitilessly. And even after a generation or so of trying the valley, a settling family might take account and find that the most plentiful things around them were sagebrush and wind. Montana holds much romanticism and cachet, and for good reason. But truth be told, this landscape is equally as tough as it is majestic, as harsh as it is visually stunning. And Doig didn't breeze over that. He told the truth: sagebrush and wind. I knew then that I wanted to live there. I wanted to know these ranchers and the descendants of these settlers. I wanted authentic Montana, and I sure got it. White Sulphur Springs is a 900-person ranching town located 100 miles from any city. It is the county seat of Marr County. Doig told stories of the Stockman Bar and the bullet holes that can still be found within. Bullets from the wild days that weren't all that long ago. I'm not sure what exactly about this did appeal to me. Perhaps the wildness, the fact that White Sulphur felt somehow more old-fashioned than most places. Or perhaps it was because it felt as though anything were possible. I got the sense that in a town like this, no one tells you what to do or what not to do. I found an old brick saddle shop for sale. I renovated the commercial Main Street space to reveal the original tin ceiling tiles from 1880. I settled into the living quarters directly behind the shop and even have 2 apartments upstairs for rental income. And the best part is that it is only 17 steps from my front door to the Stockman Bar. Perfect. I had found my place. That first winter, I had chimney fires and frozen pipes. I had one tenant bring bloody bar fights home, and the other tenant had his gun go off and a bullet lodge in his leg while upstairs. I know, it was awesome. I remember the first Chamber of Commerce meeting that I attended, and The Economist had just released a report naming Marr County as the county with the lowest income of any county in the entire nation. Again, great business move, Calhoun. But local business owners were up in arms with this report, which was frustrated in disbelief. And I recall that my only comment at that chamber meeting was, well, it's only up from here. But White Sulphur is the kind of town where for generations, its inhabitants have been shaped by the landscape, moved by the mountain views, yet hardened by the wind. The raw winters keep a person honest. It's the kind of place where you need a lot of grit, hard work, and dependable friends and neighbors just to make it. The work ethic that flows through the blood of these people runs as deep as the Smith River in its canyon walls. These inhabitants are also what makes White Sulphur so colorful. Dory's Cafe, 2 doors down from my shop, is the coffee spot for local ranchers and the sheriff. Men come from all around to visit, share the latest of cattle prices, local basketball scores, and of course the weather. But the story goes that Dory's was actually supposed to be Doris's, but the original sign maker put the apostrophe in the wrong place. And so it became Dory's and has remained so for 35 years. Ben Bullington, a dear friend and recently deceased songwriter, was our town doctor for many years. His song, White Sulphur Springs, sums up this place well. Dreams don't come easy on $7 an hour. Maybe it's a matter of what kind of dreams you have. The trout streams and the air is clean, and money don't mean everything, in a place called White Sulphur Springs. Ben always told me I should write the book on how to move into a rural community. But honestly, I was just being human. I was lonely and a little bit scared. Trying to start an apparel company is hard enough with no experience in the apparel industry, but trying to do it in a town where I didn't know a soul was even harder. So I did the only thing I knew how to do. I pitched in. I volunteered as an EMT on the ambulance. I joined the Arts Council, coached volleyball, helped out at local brandings and cattle drives. I got to know the people, and slowly but surely they learned to trust this outsider, and they took me in. I love that in small towns and rural areas, living there, it forces you to find commonalities with people that you otherwise wouldn't. We need each other, and it makes our character a little bit richer. So I want to give you a little background on my business so you can understand how the next chapter came to be. In 2006, I opened the doors to Red Ants Pants, a company dedicated to making workwear for women, the first company, in fact. And at that time, no one was making a heavy-duty work pant that fit women. And as many of you probably know, curves do not fit well into square men's pants, turns out. So the name for the company popped into my head, and it stuck. In an ant colony, it is the female ants that do all of the work. This is a true story. The male ants, they simply breed and die. So there were three things that I promised myself when I first started this company. Number one, if I can't run a business with integrity, then I don't deserve to be in business. Nobody does. Number two, if I can't operate a clothing company and keep all of our production on American soil, then I refuse to run a clothing company. Yes. Thank you. And number three, if I can't make it personal and have fun connecting with my customers, then I don't want to be in business. On paper, I'm an unlikely candidate to even be an entrepreneur. Growing up on a farm, and then I got a degree in environmental studies. Then I worked for years instructing for Outward Bound and leading trail crews. And I've never taken a business course to this day in my life. But with a strong work ethic, a good sense of right versus wrong, and just knowing how to treat people well, it is not that hard to run a business with integrity. At Red Ants Pants, all of our products are made in the USA, and that will never change. Many of them are even made in Montana now, and we're hoping to increase that. So in 2011, I was named Entrepreneur of the Year by our governor. In 2012, I was named by the Small Business Administration the National Woman in Business Champion. I was also invited to the White House. All incredible honors. But the meaning of this didn't sink in until I returned to White Sulphur Springs from DC. I headed to the Stockman for a burger and a beer. There was a cattle shipping party going on, so the place was packed. And unbeknownst to me, the local paper had written up a piece on my going to the White House. There must have been a dozen different ranchers that came up to me that night and simply said, "Sarah, you've made us proud." After about 5 years in business, we had survived the economic downturn. We're hiring more and more employees in rural Montana, and that felt damn good. But I realized we needed a big marketing push for the company. It seemed time to bring folks together on a larger scale. It was time to celebrate. So I decided to throw a party, a big party. In July of 2011, in a cow pasture just outside of town, 6,000 fans came to the first annual Red Ants Pants Music Festival. This tripled the county's population. It was by far the riskiest move of my life. I was working off a $0 budget, hoping that we could sell enough advance tickets that I could pay the talent deposits. And very fortunately, it worked. The community rallied hugely around the event, and they still do. It literally took the whole town to pull it off. Ranchers lent their land, augers, mowers, even helicopters. High school groups earned money picking rocks and filling in gopher holes. The football team collected trash throughout the weekend. County crews were watering the dirt roads, and the city supported our efforts with fire, EMS, and law enforcement. We had a core crew of staff and hundreds of volunteers, but none of us knew what to expect that first year. It was like a field of dreams. I can remember the first day we opened the festival campground, and I couldn't believe my eyes when I looked up and I saw the line of cars and trucks and campers and sheep wagons that stretched miles down the valley as far as you could see. We built it, and they sure came. We literally bought out the entire toilet paper supply across 3 counties. But the best part about the festival is that it brings people together, and this is something you all can recognize with rural medicine. We give them good music, good beer, and an incredible landscape, and they can't help but to connect with each other. One of my favorite pictures is of 2 men with their backs to the camera. They didn't appear to know each other well. They're both having a beer and enjoying the show. And on the back of one guy's shirt, it says, "Save the planet." And the other guy, who must have worked for an asphalt company, his shirt read, "Pave the planet." And you can't make that shit up, right? But to me, that's what it's all about. Let's bring people together. One of the things that sets our festival apart from other music events is our demonstration area. So we do lots of demos of traditional agricultural and work skills, like sheep shearing, sheepdog trials, ranch horsemanship. We do a big crosscut saw competition. And one of the most popular demos is our meat cutting. So this consists of a hind quarter of a cow hanging off of a tractor, where a butcher cuts the beef into steaks. The head chef from Aleworks in Bozeman throws them onto a grill, and then everyone gets to have a bite of the steak. You can see why it's popular. But the first year we did this demo, the butcher went to slice off a big chunk of meat, and it slipped and hit the dirt. So like any good Montanan, he picks it right up, trims it off, and keeps on going, right? And it was overheard in the crowd, some guy saying, "Man, this is awesome. The only place you can see this is Montana or Mexico." So I figure we're doing something right if that's happening. But perhaps the most important element of the festival is that it is a fundraiser for our nonprofit, the Red Ants Pants Foundation, and this is the 501c3 arm of our operations. And our foundation is in support of women's leadership, working family farms and ranches, and rural communities. And our values of our foundation include cultivating a strong work ethic, encouraging self-reliance, maintaining traditional work skills, and my personal favorite, providing opportunities for people with different perspectives to connect, build bridges, and discover common ground. We do a big grant cycle every spring. Our 4-year total is $45,000 we've been able to give away because we have a big party in a cow pasture, which is pretty fun. We also hold timber skills events, which are week-long chainsaw trainings, and we're working on women's leadership retreats as well. And this past summer, at our 4th annual festival, which is now a 4-day event, we had 11,000 fans come, and Charlie Pride was our headliner, and Merle Haggard was the year before that. So the governor's office and the Department of Commerce wrote an economic impact study on the music festival. They predicted that back in 2013, up to $2.8 million would change hands in White Sulphur and on the festival grounds just the weekend of the event. That's not the secondary and tertiary events year-round that we're seeing now in our community. I can't say for sure that the White Sulphur economy has improved, but I do know that this past summer during the festival, Dory's Cafe had the best day that they have ever had in 35 years. And we are no longer listed as the lowest income of any county in the nation. So last winter, I received a letter from Ivan Doig, a real handwritten letter on actual stationery, and it was enclosed with a copy of his recent book. He had heard about Red Ants Pants and of his influence on my settling in White Sulphur Springs. He told me he was really glad I had found his hometown and am making it perk. So here's to making it perk in all of our hometowns. This was a welcome letter I wrote for our 2013 festival newspaper. Thank you for being here and for being an integral part of making this field of dreams rise to life. Thank you for the hard work that you do and for making time to come celebrate. These mountains have been here a long, long time. They have been silently watching we humans in this valley for hundreds of years now. They have watched us make peace with warring tribes to share the healing hot springs. They have watched us build homesteads and one-room schoolhouses. They have watched us pull silver, gold, and copper from these rich veins and timber from these dense forests. They have watched us raise sheep and horses and the best Black Angus steaks you'll ever taste. And now these mountains look down upon us today. Let's show them that there is a hell of a lot of hope for humanity. That having a little integrity, a strong work ethic, and a big heart is all we really need. To be good neighbors, good families, and good people. And that we can all come together in this sweet clover cow pasture and just be human. Enjoy. Enjoy yourself, but even more importantly, enjoy each other. Thank you.
So the power of bringing people together is really what this weekend is about. And we've come to the end of our time here in Urey Hall this evening, but this is only the beginning. Really, what's going to happen is that a crucial part of this weekend is building new networks across different disciplines, professions, and interests. So tomorrow, I hope to see all of you at Hacking Rural Medicine at the Payne Native American Center. Bright and early, we're going to start with bagels and coffee at 8, and our kickoff is at 9 a.m. But for now, so that you know where the Payne Native American Center is, we're going to have a reception and no-host bar just nearby, just outside. Just go up, and next to the Oval, you'll find us. So no excuse for not finding the venue tomorrow morning. So without further ado, you've been a great audience. I wish you all the best. I'll see you bright and early tomorrow at a reception later. Thank you so much, and wishing you all a very good night.
Very good. Well, thank you. It was a pleasure.
It was a pleasure.
Sure will.